All right, session's being recorded. You all can see that it's being recorded by that little video camera up in the top with a recording symbol inside of it. All right, so I'm going to share my screen and show you all the PowerPoint that we have for this. And if you all have any questions at any point in time during this, just know that I can't see the raised hand function. So Bree, if you don't mind just telling me, just calling on people if they raise their hand during this, because I'll be on the PowerPoint screen.
Yep.
Thank you. All right, so the 2019 Medicare for All. I'm Hannah Call. I'm the Varsity Public Forum Lab Leader. I'm also the Assistant Director of the camp for the novices who have not heard my introduction like 5 times already. So the topic that we chose to do for PF this year, or for PF for the September-October resolution, is the United States federal government should enact the Medicare for All Act of 2019. We decided to focus on this one for the majority of the camp because we think that it has more equitable pro and con ground. We also think that it has a more diverse literature base than the other topic, and we think that there are a multitude of different options for both pro and con cases. So the other lecture the other area we're going to talk about a little bit as well, but not nearly in depth, as in depth as this one. So this is what we're going to focus on for the majority of the camp, and all of our files are also surrounded with this topic. All right, so the current healthcare structure is the first thing that I wanted to talk to you all about, because this kind of helps you gain an understanding of the differences between our current healthcare system and Medicare for All. So there's a multitude of different coverage options, including private insurance that individuals can buy themselves off the free market. Generally, these have extremely high premiums. There's also employee-sponsored healthcare. There's something called the employer mandate, in which employees are required to provide their full-time, or employers are required to provide full-time employees for insurance coverage. There's also Medicare and Medicaid, and then there's military or veteran coverage for healthcare. So the employee-sponsored healthcare generally have very high deductibles. Over $1,000 is the average. Some are a bit higher, some are lower. It just depends on the employer and their ability to provide healthcare coverage. I just heard a beep in the chat. Was that a question?
It's wondering if they should take notes. Yes, you all should take notes.
Okay. So deductibles are generally very high, over $1,000. There's also Medicare, which covers Americans over 65. Seniors have to pay 20% of the doctor costs, though. There's also Medicaid, which covers children under the age of 18 who are not able to have health care provided to them by their parents. Generally, the deductibles for this is also extremely high, and the copays are high as well. So all of the current plans, despite if they are provided for you by your employer or by the government, still require very high out-of-pocket costs, which means like the deductibles that you have to pay before you begin receiving money back, or any costs that you have to pay when you go to the doctor's office for planned visits or scheduled visits, etc., or even sick visits. All of those have very high costs that you have to pay out of pocket. So there's a lot of charts that I've found online for how Americans are insured, and there's a bunch of different ways for healthcare coverage. So this one kind of shows that there's a lot of people that are uninsured. So pre-COVID, and I think this number is from 2018, from the 2018 census, there were 8.5% of people that were uninsured. And the charts are from 2016 because those are the most updated ones that I was able to find. But the numbers before COVID, 8.5%. Republicans were looking to overhaul Medicaid, which covers about 60 million people. And then Democrats also wanted to go away with employee-sponsored healthcare, which covers about 56% of people. So there's a bunch of different options for ways that people are trying to overhaul the healthcare system now. And yeah, so this chart over here shows that 91.2% of people were covered with health insurance. There are a lot of people who are covered by private plans. This is by I believe this one's by the million, or yeah, by percentage as well. There's a lot of people that are covered by employee-based insurance and also direct purchase insurance. All right. So coverage by race and ethnicity. So there's a lot of disparities with racial and ethnic disparities for healthcare coverage. As you can see on this chart, there are 16% of Hispanics who are not covered by healthcare. 10.5% of Black Americans are not covered by healthcare, compared to just 6.3% of white people. So a lot of this kind of comes with there were 20 states that refused to do the Medicaid expansion that was under Obamacare. Those states are particularly in the South and particularly a little bit more racially diverse. And those states refused to do Medicaid expansion, which kind of accounts for this. The Trump administration also cut off contact with the Latino groups that were working with the administration to receive coverage, which includes a lot of people, residents of the United States who might not be citizens yet. So immigrants whose status might be green cards, et cetera. So there have been some issues that have happened in the current administration to reduce the amount of healthcare coverage and increase the racial and ethnic disparities that exist now. So coverage by age, there's some obvious gaps in the middle there. This chart shows different coverage by age gaps based on the year. Fortunately, it's been decreasing a little bit since from 2013 to 2016, although obviously it's spiked a bit more with COVID. Medicare covers seniors, Medicaid covers kids. There's a spike in the mid-20s. This is because Obamacare allows for children to remain on their parents' insurance until 18. Obviously, everyone under is covered by Medicaid if they do not have pre-existing health care, and then seniors over 65 are covered as well. There's a little bit of a gap between like 26 and 33 or so when people are coming out of their parents' insurance and might not have full-time jobs yet, in which their employers cover their health care, and maybe they can't afford the private market health care either. So coverage by state, it's obvious that Texas is the one with the highest uninsured rate. They have over 14% of people who are not covered in healthcare. Massachusetts is the lowest. I think it was like 2.5% of people in Massachusetts are not covered. Some other southern states, it kind of aligns with 20 states that did not expand Medicaid or Medicaid under Obamacare. So Florida, Alabama, Georgia, et cetera, all of those states have relatively higher percents of uninsured rates. So some additional issues with the current healthcare system: more than $10,700 per capita is spent on healthcare. And this is kind of compared to other countries that have a single payer system currently. So Canada spends well under half, along with France, which saves significantly on administrative costs, et cetera, which we're going to talk a little bit more about in a minute. Healthcare spending also consumes a lot of our nation's GDP. It's about 18%, which is pretty extraordinary compared to some other countries. So the life expectancy rate is another interesting fact in our current healthcare system. So it's 2.5 years lower than Germany's life expectancy rate. Germany is another country that has a single payer healthcare system. The mortality rate for children under 18 is at the top of the list compared to other developed countries. So even though those children have coverage through Medicaid, clearly efficient to provide for their needs. So there are obvious issues that exist with our healthcare system. There are a lot of solutions presented to try to fix it. However, those are not working. So here is an example for what Medicare is. So this is the federal health insurance program. So people who are 65 or older are covered under Medicare currently. It covers certain younger people with disabilities. It also has people with other diseases, particularly like kidney failures covered under it, et cetera. And then it also helps cover some specific services. Medicare Part A covers hospital insurance, so stays in a nursing facility, hospice care, and some home health care. Medicare Part B covers medical insurance. Medicare Part D covers prescription drug coverage. I'm not going to go through all the bullet points here because you can see them for yourself, but these are just some examples of what Medicare currently covers. So there's a lot of things that are not currently covered under Part A and B, though. So some services that are not included: long-term care is one of the most notable ones. Dental care is another one. Some eye exams, dentures, cosmetics, acupuncture, foot care, some other stuff. So things that are not necessarily critical surgeries or critical procedures are not necessarily covered under Medicare Part A or B. And then Part D is just the prescription drug coverage. All right, so before I move on to the MFA, I'm going to go back to Blackboard and look at you all. Do you have any questions for me so far on current Medicare coverage? Any questions at all?
I have a question. Could you go back to the slide, or if you wait, I didn't see like a Part C, so I was wondering what that was.
There's not a Part C, it's just Part A, B, and D. So Medicare Part A is the hospital insurance, B is medical insurance, and then D is drugs. I don't believe there's a Part C, and if there is, then I'm just overlooking that. But yeah, so this just covers those three things.
Thank you.
Yeah, question?
So you mentioned that 18% of the GDP is spent on healthcare. So is that like, does it mean healthcare in general, like individual healthcare? So also on like private healthcare and government healthcare and whatever, or does it just mean what the government pays for?
So it's all of the money that currently goes into the healthcare system. So administrative costs that occur along running private healthcare, the taxes that people pay to cover their employer-sponsored healthcare, any money that goes into the GDP from healthcare. So it can be any different type of it. Generally, that does come out of the government funds, right? So the GDP is basically how the government spends money, but 18% of that is healthcare.
Okay.
Any other questions?
Did you say that employee-sponsored healthcare covers 56% of Americans?
I believe that was the number, yeah. Let me go back.
Okay.
Yeah, 56. And that number was in 2018 as well. All right. Awesome. So now we'll move on to the 2019 MFA and kind of discuss what this is, because this is obviously what's relevant. So the bill is something that establishes a national health insurance that is administered by the Department of Health and Human Service. It would cover all U.S. residents. So this includes people whose immigration status might not be full citizen. It provides automatic enrollment upon birth or residency in the United States. It covers items and services that are medically necessary. It prohibits cost sharing and other charges for covered services. So that means it doesn't have any out-of-pocket costs when you go to your doctor's office. It doesn't require that you pay any deductibles. For surgeries, it doesn't require that you have to pay a copay for office visits, etc. So all of it would be covered under the bill. Private insurers and employers cover supplemental coverage, so employees are not able to use healthcare as a draw-in to their job. Rather, it would just be something offered as supplemental coverage if you want to have maybe better coverage in addition to the coverage provided to you from the government. So employer-sponsored healthcare would no longer exist. The employer mandate would be done. So breaking that down, it's a single payer system. So what that means, because this term is going to appear a lot in the files and is also going to be something that we talk about a lot during the next couple of weeks. What that means is the government administers and pays for all of the costs. So we have a multi-payer system functionally where the free market covers some of the healthcare, where employers cover healthcare, where individuals buy their own healthcare off the markets, where Medicare and Medicaid are covered under the government. But this would just be a single payer system in which the government covers all costs associated with healthcare. It would cover all Americans. It's much more generous. This particular proposal, the 2019 Medicare for All bill, is much more generous than other countries with single payer. We'll do some comparisons in a minute. It would most likely, one of the things that's notably absent in the bill is how it would get paid for, because obviously there would need to be some way that the new system would be paid for, which would likely require tax adjustments, is what's happened in other countries with a single payer healthcare system. And those are notably absent in the bill that's proposed. So that's something that a lot of people in Congress have been debating, and something that the CBO officially came out with and said that needs to be determined prior to the bill moving forward. Employers would be unable to offer competitive insurance. So it kind of also sunsets Medicare and Medicaid. And by that, I mean they're folded into the bill. So if you have current Medicare and Medicaid coverage, then those would still exist within the bill. Two forms of healthcare coverage that would exist within the bill are Veterans Affairs coverage that would not be done away with, and then also the Indian Health Services that would still exist too. Americans with disabilities would be covered at home or in community settings compared to currently they are covered under, some are covered under Medicare, but not all. Prescription coverage, prescription drugs would be out of pocket spend, those would still have a deductible. So those are the only things that you would really have to cover now, whereas Medicare Part D only covers part of it. This would be covered about the same as Medicare Part D, but for people who do not have prescription coverage under like their free market plan or under their employer-sponsored healthcare, would have a bit more prescription drug coverage under this plan. So it covers a lot of different services. It covers hospital visits, primary care visits, medical devices like MRIs, CAT scans, et cetera. It covers lab services, so blood work, any testing that you might need done. It covers maternity care, OBGYN visits. Prescription drugs are covered, but they're not fully covered. And then also vision and dental benefits. So that's another big distinction from the status quo, is dental and vision benefits are not covered under most healthcare plans. There are separate plans that you have to purchase, whereas they would be covered under the healthcare plan with Medicare for All 2019. So compared to other countries, Canada does not cover vision, dental, prescriptions, or home health or rehabilitative centers. Netherlands and Australia does not cover dental and vision. Taiwan does cost sharing for doctors' visits, whereas all of that would be different within the United States. So Canada or the United States would cover vision and dental, and also some of those prescription drugs. Netherlands and Australia don't cover vision and dental, which obviously the United States would do. And then also there would not be cost sharing for doctors' visits. So for congressional discussions, it was introduced in the House. There's not really been any further action to date for it. It has kind of stalled there due to COVID-19 and some other issues that exist in Congress now. The 2020 election obviously was a key campaign platform for Bernie, and it will probably continue forward upon resuming sessions and after the 2020 election. All right, so main controversies that exist with it. Before I move on to this section, do you all have any questions? Any questions for this section?
Yeah, can you define what cost sharing means?
Yeah, so that's a good question. Cost sharing is functional like any out-of-pocket cost that you would have to pay. So it kind of comes down to a few different things. So the first is if you go to the doctor's office and you have to pay any kind of copay, that's one form of cost sharing. Cost sharing is also like the different costs between like the government and then your deductible. So if you have to pay a deductible for any services, that is another form of cost sharing. Just any way that you share costs with the government or you share costs with your free market plan. Does that make sense, Aaron?
Yes.
Okay. What else? Any other questions about that? I know that was kind of a lot of information. All right, I'm going to go ahead and move on then. So some main controversies with Medicare for All, healthcare spending. So there are some known benefits to it. The most obvious one is administrative waste. There have been quite a few studies that have come out in the past 2 decades that have shown the amount of administrative waste that goes into healthcare. So the first was a study in 2003 that showed that we spent double the amount that Canada spent in healthcare, the percentage that Canada would spend in healthcare, obviously not the overall amount. A 2011 study, once Canada began transitioning to a single payer system, showed that we spent 4 times as much money in administrative waste. We are also ranked the highest for healthcare spending for administrative costs than other countries. So if you look at this, we have 8.3% in 2006, compared to France that had like 5.7%. So single prices would be set across the board for different services in a single payer system, which would eliminate a lot of administrative waste because there wouldn't be as much paperwork determining how much different services cost for different people. So it would be pretty surmountable. So some possible side effects for it, though, is that more doctor's trips would likely occur because people would feel like they have the coverage necessary to go to the doctor more often, which would increase the amount of payments that would occur to the doctor, which would likely increase the amount of taxes that we would have to pay. Medicaid prices would also probably be raised as an offset to that as well. So here are a bunch of different ways that it might be paid for. These were some options I think that were presented maybe in the bill itself, if not just some scholars doing some studies. None of these have been solidified, but these are options that it could be paid for. So a 4% income-based premium by employees could be one example. Imposing a 7.5% income-based premium by employers could be another example. Eliminating health tax expenditures, making the federal income tax more progressive. A lot of different options for how we could do that, most of which just kind of boil down to increasing tax rates. The amount that those tax rates would increase, though, is obviously the question. A lot of people have suggested we should do it progressively based on the amount of income that certain families make. A lot of people have suggested it should just be a fixed rate for increase. There are obviously people who are trying to determine how we can offset the amount of taxes that would have to be paid by the cutting of administrative costs and the benefits that would provide economically. So there might be a chance that taxes would not have to increase if we were able to do that, but it's kind of still unknown and up in the air. And a lot of people are doing a lot of studies and determining how we can pay for it. So the CBO has listed some official considerations for the bill because there are a lot of questions that still exist after the official release of it. The first is how would it be administered? So obviously that there needs to be a way that everyone is enrolled into the healthcare system. So how does that enrollment occur? How does the government administer it? How does it make everyone aware that there is now a single payer healthcare system, right? So there's a bunch of different ways that we need to figure out how it happens automatically or if someone has to enroll, et cetera. Who would be eligible for the plan is another question that is asked. So would this include everyone who is currently in the United States? Does it include only residents of the United States? Who is covered under a single payer system and what benefits does it cover? So a lot of the benefits were already kind of debated and established, but there needs to be some formal agreement upon those. So what cost sharing, if any, would the plan require? So are there any copays that are required alongside the system? Are there any deductibles that people have to pay, et cetera? What role would private insurance and other public programs have? So would the free market still exist? Would it be eliminated in its entirety? Would it be allowed to be supplemental to the healthcare system, as I stated earlier? Similarly with employer insurance, would this be allowed to be supplemental? All those questions. And then which providers would be allowed to participate and the hospital and who would own the hospitals and employ the providers? So this is another question because we need to figure out if hospitals would be owned by the government, if they would be owned by private industries, how all of that system would function. How would the single payer system set provider payment rates and purchase prescription drugs? How does it contain healthcare costs? And also how would it be financed? So a bunch of economical questions that the Congressional Budget Office has listed as considerations for Medicare for All. All right. Before I move on to its relevance for debate and some diving into the files, do I have any questions on Medicare for All and some considerations for it?
I have a question. So
Yeah.
if this plan went through, would the government own hospitals and specialty care centers and employ doctors, or would it just provide insurance?
So that's a really good question, and that's something that's not been determined yet. That's one of the things that the CBO said they need to figure out before the plan passes.
Can you go back one slide, please?
Yeah, sure. Yeah, there was a lot of stuff on that slide. I'll give you all a few more seconds to write this one down. What other questions do I have? Before this lecture, had everyone kind of heard of Bernie's Medicare for All plan or been familiar with the term single payer? Is this kind of brand new to anybody? I know that before we had a topic in college policy debate on pretty much this 3 years ago. And before that, I was not really too familiar with it, but I became very familiar over a year of research for it. So that might be new to a lot of people, and that's fine. But just a show of hands who was kind of familiar with it beforehand and knew a little about it. All right, so a few of you. Who was like, this is brand new, and I was never familiarized with Medicare for All or single payer before. All right, cool. Thank you for your honesty. Other people in my lab, is this brand new to you, or were you familiar with it? Anyone?
I had a general sense of what was going on, but I didn't really know most of the details.
Yeah, me
Got it.
too.
Okay, cool. Whoever asked for this slide to be left on, are you good? Can I move on? I'm going to take that as a yes. All right, so its relevance to debate and the topic and why we are debating this one and why we have chosen this one. So it's really good for PF debate. This resolution is very simple and precise. It's exact. There is a very focal point of ground for both pro and con. It's extremely balanced. I think it might honestly be one of the most equitable side resolutions that I've seen for PF in quite a long time. There's a litany of literature out there for single payer and Medicare for all. There's a lot of statistics. There have been a lot of studies. It's extremely timely. There's a ton of options and strategies that you can deploy in debates with single payer and Medicare for all. There's a ton of alternatives that can be suggested. I hear Bree laughing at me in the background, even though she's not doesn't have her mic on. It references real policy with a lot of evidence. So there's a lot of reasons that I think this is a really good topic for PF. So some pro areas, there are notably going to be more con areas listed here than pro areas, but that's just because when we debated this topic for college, the AF case was pretty good, so we had to find some like kind of wonky con or neg cases. So those are listed here. But the pro areas, solvency arguments, novices, that's kind of like how you solve for the issues that exist. The solvency arguments are very good. So for health, there's some coverage and access arguments. So obviously it would increase the amount of coverage that people have. There's some impacts for that. So like just disease, COVID scenarios, bioterror. There's also some arguments about the right to healthcare. There's a big debate on whether or not healthcare is a universal right or if it's something that is earned. Social justice arguments, so kind of racial and ethnic disparities that we talked about earlier. There's a lot of arguments for economy and costs. There's going to be a whole lecture on this, I believe, on Wednesday. So some of the ways that this is debated for the pro are deficit reduction, job creation, business confidence, that's called BizCon as a buzz term, administrative burden, consumer spending, productivity, wages. All of those are some ways that can offset economic losses and increase the economy through different gains. There's also cooperative federalism. This just means that the state and federal government can work together to implement an effective system. So a lot of the arguments out there say that the way that it would be administered is the government would administer it federally, but then the states would be left to kind of choose how hospitals and doctors administer it. So that's kind of one of the arguments for cooperative federalism. There's also a military spending argument. So there's an argument now that healthcare spending trades off with military spending. We spend most of our money on the military. However, healthcare, I believe, if I'm remembering this correctly, is a close second to military spending. So the amount of money that we're spending on healthcare could transfer over to military spending and increase the amount of resources that we're able to dedicate there. There's some arguments for farmers not really having enough insurance and their costs are skyrocketing because of it. I think I have a question.
That's me, Hannah. Can you go a little bit slower?
I'm sorry, I talk really fast and I try to go slow. So yes, Brie, I will go slower. I'll try to. So the cost for farmers' healthcare coverage is skyrocketing, which means they're not really able to be quite as productive, and that might hurt agriculture. There's also some arguments about data sharing. So if we're able to collect all of the data for healthcare, then that can help us with AI leadership and kind of offset our losses against China's AI leadership. So some con areas. The obvious way to kind of go about this is by some solvency takeouts, or saying that the pro does not solve their scenarios. The first one is saying that it doesn't actually increase access or coverage, because not everyone would know that a single payer system exists. The second one is circumvention, which is just a fancy way for saying the government decides to roll back or take away the plan, or there are some loopholes that exist and we are able to have free market healthcare still exist, etc. Or maybe Trump doesn't really like single payer healthcare, so he decides to go around it and implement a system that is better for the free market. There's also some arguments about wait time. So maybe those would increase because people would have more coverage, but more doctors' offices and hospitals would not increase. Then there's also some arguments about rationing. So we would have to ration out the healthcare service. Doctors might quit because they would feel overburdened. So those are some obvious solvency takeouts. There's a lot more, but those are some examples. The economy, you're going to see this again. I will tell you that when this was a college topic, the economy was probably the biggest scenario. I don't know if there was a debate that I judged that did not have economy arguments late into the speeches, just because of how prevalent it is and how much literature exists surrounding the economics of a single payer system. So some arguments against single payer system or Medicare for all are taxes. Private industry insurance is maybe cheaper overall. It would cause unemployment because people would no longer have jobs just for healthcare coverage. It would increase the deficit. Maybe it decreases business confidence or BizCon. Some other areas are data. So we talked about data for the pro. There's also a data argument for the con. So it might cause deportations because individuals who did not previously have healthcare and whose immigration status might not be full citizenship could be deported if they receive single-payer healthcare under the Trump administration. There's also some arguments for identity theft and hacking. So obviously, if we have to put our data into a big system, then there's a risk that our identity gets hacked. There's some doctor-patient trust arguments. So if we no longer have quite as much time spent with our doctors, it can decrease the amount of trust that we have in them. There's a decentralized federalism argument, which is the opposite of cooperative federalism. And decentralized federalism functionally just states that it is up to the states to determine how healthcare functions. It is not up to the federal government, which means that the way that the plan or the pro case goes about it is kind of wrong. There's also some arguments about innovation, so biotech and pharmaceutical innovation, pharmaceutical R&D. There's more arguments about military recruitment, so free healthcare ensures recruitment. There's a lot of statistics out there that say a lot of people join the military for the healthcare benefit because of how expensive it is. So if we were to eliminate that, then it would decrease the willingness for people to join the military. Maybe opioids would be overprescribed if people continue to go to the doctor's office. There's also a pro argument for opioids, saying that it would lower the opioid epidemic because people would now be going to the doctor instead of receiving them illegally. There's also an argument for trade, so it violates GATS or violates different trade agreements, which would offset trade overall. A few more. So medical tourism is another example. So we would have to go to other countries now to receive medical services or we might go to other countries now to receive medical services because they're cheaper. But if we implement a single payer healthcare system, then it would decrease our willingness and desire to go to those countries to receive those treatments, which means it would be less money going into those countries' economies. There's arguments for what we're going to talk about later in my lab, and novices who are not given these yet, states counterplan. So it's better to implement a single payer system through the states, and maybe the free markets are a better way to implement a better way to have healthcare. They're a better alternative to single payer, maybe for economic reasons. Lastly, for con areas, there's some arguments about biopower. We're going to have a lecture on that later next week. So just like state control of healthcare is bad. And there's also some coercion, or a coercion argument, which is kind of silly, but it's just taxes are theft and we should not have them at all. And obviously healthcare would likely increase taxes, or single payer healthcare would increase taxes, and that's bad and morally bankrupt. So does anyone have any questions on how it applies to PF before I go into a couple concluding thoughts? I know that was a lot. The briefs kind of break all of this down for you. Michaela.
Yes, I actually have a question about the pro side. So in this in the debate, does the pro side have the burden of determining how it's going to be paid for?
So that's a really good question. I would say no. And that's because since it's pointing us to a specific bill and that bill has not yet been determined for how it's paid for, it is not your burden as the pro to make up how it's paid for.
Okay.
I also
Erin?
think, can I add on that before you move on, Hannah?
Yeah, go for it.
So I agree with Hannah that I don't think it is your burden, but I think it is a plausible con argument in the sense that if the con does get up and say, like, it's not a good idea because you don't know how it's paid for, and they give other reasons or they give reasons why a potential way they pay for it could be bad, then that just means you need to have a good preemptive argument as to why that is not your burden, or why the possible ways to fund it could be good or offset the cons that they're outlining, or just decide what you will or will not defend. But that'll get more into it when you actually start putting your pro cases together. But I think it's an argument you should be prepared to have.
Yeah, absolutely.
Okay.
Erin?
Yeah, so there was I think it was a pro argument about trade-offs with military spending. Can you talk a little bit more about that?
Yeah, so the evidence for this is like kind of iffy, to be honest with you. It's not that great, but it does exist. So the argument is that we spend a lot of our budget on healthcare. The number was like 18%. The highest industry that we spend our money in for GDP is the military. So the argument would just be that we do not currently have enough money going into the military despite how much goes into it. If we were to reduce the overall amount that healthcare costs for our GDP, then that money would logically go back into the military, which would allow us to increase maybe different weapons developments or presence in foreign countries, etc.
Then I have a question. If the money could theoretically go somewhere else, is it also a burden on us to say where else that money would theoretically go and how productive it would be, like comparatively?
It is. You would need to have evidence that says it would go to those places if you make that argument. Which is why I said it's not that great. It's just like a trade-off argument. So you could say that it goes somewhere else if you want to. If you don't want to say military, maybe you could say like it goes into education. But it would be on you to show that it goes into those systems.
Can
And
you
you would
please
need to
go
have
back one
evidence that
slide
shows.
again? Sorry.
I can. No worries.
Thank you.
You're welcome.
Oh.
Another slide.
Yeah, the one before this one. Sorry.
There you go.
Yeah. Thank you.
You're welcome. Do I have any other questions about ground? All right, so some concluding thoughts, and I think this is pretty short if I remember correctly. So some notes, and this goes along with what Bria was saying earlier. Both sides need a position on economy. It's going to become one of the most forefront issues of the debate. Pro team, if you do not want to have an economy contention, you should preempt it or have a very good rebuttal strategy for economy. We'll talk more about that in lab in detail. Both sides also need a position on access and coverage. This is the second biggest issue of the debate. So however you choose to impact those things out is up to you, but you need to have some kind of position on it on both sides. All right, that concludes it. I was right at almost at 45 minutes free, so I almost did it. Do I have any questions at all for the last of it? No? My lab, we're going to have a Kahoot on this. So if you have any questions, I would ask them now. Yes, Natalie.
So one of the con points was that the free market is a better alternative to the single payer system. Could you go in more in depth into that?
Yeah, so that argument's just like we should allow for the markets to kind of do their thing. So it's both an argument about why the status quo is good, and it's also an argument for how we should expand free market healthcare. So the amount of healthcare that individuals are able to purchase off the free market, maybe lower the costs for that overall. Just some reasons that would be more economically beneficial. Maybe it would not increase taxes as much. Maybe there would be more money going into the GDP overall. Maybe the amount that single payer offsets administrative costs wouldn't be nearly as surmountable as the amount that free market healthcare would go into decreasing the deficit. Any examples like that?
Okay.
Does that make sense?
Yeah.
Okay. Zane?
That's like not really on this topic, but when we debate, do we get to use our notes? Like, do we get to have them up?
Yes.
Okay, thank you.
Yep. And you're going to turn those things into, you're going to turn your notes into things called blocks, but Bree will talk with you about that as the week progresses. Any other questions? All right, awesome. This lecture is going to be made available for you all in PDF format under that morning lectures link on Blackboard. My lab, we will meet back in the afternoon room in 5 minutes. So go ahead and take like a 5-minute break. And then Bree's lab, that is up to Bree.